innovations in drug therapies play a crucial role in the prevention and management of cardiovascular disease, particularly at the primary healthcare level. Effective and affordable drug interventions are essential in improving outcomes for cardiovascular disease patients. This session will explore the latest advances in cardiovascular pharmacotherapy, focusing on innovative drug interventions that can be integrated into the primary healthcare settings. So, what are we going to discuss in this session? The risk factors such as hypertension, hyperglycemia, dyslipidemia are usually not associated with symptoms. On the other hand, treatment of these risk factors may have nagging side effects. The adherence, therefore, is dismal, necessitating corrective strategies. Number two, the latest advances in drug development targeting cardiovascular risk factors, especially the mRNA therapeutics with 6 to 12-month efficacy with negligible side effects, may allow novel intervention strategies. Three, could such interventions be incorporated in primary care? Would they improve adherence with the simplified treatment regimens? And four, how can we evaluate the efficacy? And if effective, how can we address the cost barrier, especially in the low resource settings? So I would like to invite the panel members first. Professor Tazeen Jaffer. She is Professor of Health Services and Systems Research at Duke National University of Singapore Medical School, Singapore. Dr. Sameer Bansilal, Global Head of Medical Affairs, Amyloid Therapeutics Area, and Al-Nilam. Then Professor Andrea Brandau, WHF board member and Professor of Cardiology, Rio de Janeiro State University. And lastly, Dr. Lutz Hegman, a fellow of the Royal Society of Tropical Medicine and Hygiene, and he is the president of Novartis Global Health and is especially passionate for transforming health in low and middle income countries with program targeting cardiovascular disease risk factors, malaria, neglected tropical diseases, and NCD such as sickle cell disease. So, Dr. Hegman, can I first invite you to give us the pace setter lecture? And I don't think you need the clicker. Okay.
No, with pleasure, Dr. Narula. Thank you very much for the kind invitation, dear colleagues, ladies and gentlemen. It's a distinct pleasure to be here today at the 10th World Heart Summit, especially also in my new role as co-opted member of the board of the World Health Foundation. Cardiovascular disease, and we've heard this morning again, is the world's largest public health challenge with an estimated 200 million deaths per year. Most premature cardiovascular disease deaths occur in low and middle income countries and occur at a very young age, most of them before the age of 60. And even in high-income settings, we are seeing a new surge in cardiovascular disease, particularly affecting marginalized populations. We've also agreed this morning that current approaches fail to address the ever-increasing pressure on health systems and to achieve the desired outcome at patient level, which is often linked to poor adherence. Especially with demographic and climate change accelerating the burden of cardiovascular disease, it is imperative that we put cardiovascular disease on the international health agenda and advocate for new approaches, and the World Heart Federation is a key actor in doing that. Today's discussion on innovations in drug interventions for cardiovascular disease and primary health care level is timely and needed. And we are indeed in a unique position where we now have the most advanced innovative medicines and treatments for CVD, and the key lies in unlocking better patient outcomes by beating cardiovascular disease before events occur. Only with targeted interventions, and by that I mean large-scale diagnostic efforts and prevention approaches, and that needs to be done at population level, we will be able to meet our goal of treating 500 million more patients with hypertension by 2030, as we were just reminded by the quiz. Recent scientific and technological advances, especially the introduction of long-acting RNA injectables to control cardiovascular disease risk factors, in my opinion, hold the greatest promise for better population health outcomes, especially in resource-constrained settings. This may sound counterintuitive given the challenge of bringing innovative and often costly medicines to large populations, including the poorest and most remote areas on the planet. Let me share a few practical examples from our programs at Novartis Global Health to illustrate these points and to show what can be done. We are increasingly investing in community health, whereby we are working with civil society and the public sector. This applies to a broad spectrum of diseases, as Dr. Narula said, including sickle cell disease, where together with local health systems, we started our first program in Ghana 7 years ago, we are able to establish a continuum of care that starts with newborn screening and then provides basic medicines all the way to disease-modifying treatments that now allow patients in sub-Saharan Africa to have a life expectancy that compares favorably to patients in high-income settings. Other examples include infectious diseases like malaria or leprosy, but also training community health workers to track down the hidden pockets of hypertension, hypercholesterolemia, and diabetes to increase diagnosis and treatment. This brings medicines closer to patients on the margins of healthcare, many of whom may never have otherwise accessed treatment if treatment had stayed in urban tertiary hospitals. Another example comes from Vietnam, where we started a program 10 years ago, and we are now able to treat 200,000 patients per year, which is a success that saw the World Bank invest $10 million into the Ministry of Health in Vietnam to scale helping more patients to access innovative medicines. And we are now embarking on replicating this in several other low and middle income countries. We are looking to expand into countries like South Africa, Mexico, parts of Brazil, and recently launched a program in Rwanda. Here in Rwanda, in close collaboration with the public health system, our community health program has several differentiating features to maximize impact. It takes a multi-disease approach to accommodate that cardiovascular disease covers several types of diseases and risk factors, including hypertension, diabetes, dyslipidemia, and cardiomyopathy. And we spoke this morning about the challenge of multimorbidity. We aim to tackle these holistically and introduce innovations like cholesterol testing at lower levels of care. The aim of this program is to shift the sheer amount of people into primary care facilities, such as health centers, while also building district hospital capabilities to strengthen referral pathways and provide more connected care. Once the foundational program is fully established in Rwanda, we will explore the possibility of adding preventative medicines such as siRNA therapeutics, in our case inclisiran, which sees patients take an injection every 6 to 12 months, as Dr. Narula reminded us earlier, that seeks to lower the amount of cholesterol and minimize the risk of strokes and heart attacks at scale. In sub-Saharan Africa, a region where we have been committed to for many decades and provide access to innovative medicines across 46 countries, we are also looking at health system strengthening approaches. In addition to providing these innovative medicines, we are upskilling about 15,000 healthcare professionals annually through interventions with HCP associations, non-governmental organizations, innovative partnerships, and so on. The Echo for Life project that we started in Kenya uses portable smart ultrasound devices to enable timely diagnosis and follow-up. And in the last 3 years, it has helped detect more than 25,000 patients with chronic heart failure. Another, and that's my last example, very promising approach that looks holistically into health systems at city level is our Cardio for Cities program, a population health approach that was created by the Novartis Foundation and will be discussed in greater depth at this program here tomorrow. Enabling data-driven decision-making and unlocking the power of multi-sector partnership, Cardio for Cities now reaches over 40 million people and has proven to be impactful, cost-effective and scalable in different geographies around the globe. In this case, after a short implementation period of about 1.5 to 2 years, the program managed to increase blood pressure control rates in the pioneering cities of São Paulo, Dakar and Ulaanbaatar up to more than 3 times. This translated into remarkable reductions of up to 13% of strokes and 12% of acute coronary event rates. Now, looking for commonalities between those examples that I shared, I would like to share a few characteristics that those have in common. Firstly, we need to look beyond medicines and at the entire patient journey from awareness, diagnosis, treatment, and adherence to treatment, and we need to measure impact of our interventions along the way. Second, we need to enhance access to innovative treatments, not only generic medicines, at the community level by strengthening the primary health system's capabilities. And thirdly, we need to accomplish this sustainably and at scale, and in doing so, we need to work in partnership with many other actors within the health sector. For instance, in Rwanda, we have been partnering with a local non-governmental organization called Health Builders, who have the best understanding of the on-the-ground realities and working with the Rwandan government, new data systems that are rolled out as we speak, both at the community and health center level. This allows for new approaches of data collection, impact measurement, and ultimately further supporting the adherence of patients and also enabling policy decisions. In closing, ladies and gentlemen, let me say that the world, in my opinion, is at a critical turning point for global health, with demographic and climate change accelerating the changing burden of diseases, both infectious and non-communicable diseases. At the same time, we are seeing declining funding from many long-standing donors. As the world changes, we all, including my own sector, the pharmaceutical industry, needs to adapt. In a complex health system, the only way we can successfully reach our targets is by working together, staying the course, challenging ourselves to do more and to do better. I thank you very much.
Thank you, Lutz. Compliance, adherence, it's a major problem. We all know that. 10% of the hospital admissions in Europe, they are because of the non-compliance or non-adherence issues. Hundreds of billions of dollars wasted for the care which could have been easily avoided. What can we do about it? Multiple things have been done. Polypill, single pill, both in the primary healthcare setting as well as in the primary care as well, primary prevention and secondary prevention. They have been tried with some impact. Money has been given, financial support has been given with some impact. Other strategies have been tried. So WHF, or the World Heart Federation, this year started a new initiative which is called the World Adherence Day. That was initiated on 27th of March this year, and we reached out to 500 million people on that day. And there were 14 of the industry partners which worked with us towards trying to see whether we are able to influence the compliance and adherence to the medication. How exactly can we do that? In my mind, I see that there are three major ways of doing it. One, obviously, that we improve the formulations, whether we make them as the poly pills, we make them as the single pills, or whatever else we do, we basically make it more convenient. Or we create the long-acting, as in the morning also, as it was discussed, that we can have like the mRNA therapeutics, where we can make it into a 6 to 12 month therapy, and we can just use it like a vaccine, and we might have a much better compliance. That the second possibility is that we have more passion, more compassion. Can we really spend more time with patients? When I was in New York, there was one of the physicians in Harlem who had 4 clinics in Harlem, and his wife, who would order multiple pills, and as we know that the pills are not very costly, she would sit down with a pill box and literally fill the pill boxes for the patients and will give it to the patients. These are the Medicaid patients. They do not want to go in the CVS in front of his shop. They don't want to give $10 for the copay. They don't want to stand in the line and get the medicines, and here they get the pill box. And I distinctly remember having seen one patient there, and I called it a people's polypill. And what was that this person comes back with the pill box and says on 14th and 15th of February, I could not take the medicines because I drove to Philadelphia to meet my daughter and could not return back because it unexpectedly snowed heavy on that day. Is that a compliance? Another possibility, we have to have a better education. How much can we educate people? Can we build it into entertainment? We tried that this year. And with my very good friend Leo Hofstra, who is somewhere here in the audience, and we wrote a double murder mystery talking about the medicines. They are not being taken. Two of the aristocrats, they die, and later on find out that their young wife basically was withholding their pills and was replacing it with placebo. But in that, we weave in the entire thing. People say that we don't have the symptoms. Now we get the symptoms. I start getting the muscle pain. I start getting dizzy. I start getting woozy. That is the reason I don't want to take the pills. And then the other one says, you know what, now my blood pressure is normal. And if my blood pressure is normal, why should I take the medicines? Or my father had the disease, my mother had the disease, I'm doomed, why should I take it? So let us see what exactly we can do about it. We have dealt it all in that book, and we are releasing it chapter by chapter with World Heart Federation, dedicated to World Heart Federation for the World Adherence Day. And we think we are Charles Dickens, by the way. But anyway, so let me start asking this, and let me try to put it in perspective for the August gathering here. I would like to start with Andrea first. So Andrea, you have a vast background from general cardiology practice to leading the Brazilian Society of Cardiology, and from regional leadership to global policy engagement at the World Heart Federation. It gives you a unique perspective of both the clinical realities and the financial complexities. How would you approach the mitigation of risk factors driving cardiovascular disease and non-communicable diseases? Should we consider expanding the use of polypills among asymptomatic but high-risk individuals? Have such strategies shown success in Brazil, where you practice? And do you see them as scalable? In your view, how could we consolidate such a strategy by reinventing it, refreshing it, or replacing it altogether? It's a long-winded question.
Yeah. Many questions. So thank you very much, Professor Narula, for the invitation. It's a pleasure to me to be here and to take part in this important and challenging discussion. And I come from Brazil. And as is the case in many low and middle income countries, we face significant difficulties in healthcare delivery. Resources are limited, regional inequalities are vast, and a large portion of the population depends heavily on the public health system for access to care. No doubt that cardiovascular disease is the leading cause of death and disability. That's why the identification and effective management of cardiovascular risk factors must be a top priority. And this involves not only access to health services and medications, but also involves some complex factors such as improving adherence to treatment and overcoming therapeutic inertia. In Brazil, we have the Unified Health System, the SUS, which is designed to provide free health care, including medication, to the entire population. And we have like 75 to 80% of our population that depends on this system. It is the largest item of our national budget, but even so, the resources are never sufficient to meet all the needs. This reality, in my view, demands solutions that are simple, cost-effective, easy to implement, and acceptable to public and to healthcare provider. One of the strategies, and of course talking about medications in primary care, one of the strategies that we've been focusing on is the use of single pill combinations, because this is an approach that has the potential of significantly increase the control of cardiovascular risk factors. They are more effective, better tolerated, they improve adherence to treatment, and which in turn helps to reduce therapeutic inertia and improve clinical outcomes. To be clear, I'm not referring to polypill, the classical polypill, but rather to specific single pill combinations for each condition, such as hypertension, as well as dyslipidemia and type 2 diabetes. There is a clear trend in international guidelines recommending the use of combination therapies for these conditions. Multiple daily pills, of course, and complex regimens are hard to follow correctly. That's why we see this strategy as one of the most practical innovations for countries like Brazil, with large populations, geographic challenges, and limited resources. Of course, new drugs, and I will use the example of hypertension, like zilebesiran, with subcutaneous injections every 6 months, are very promising, no doubts. But we still need more evidence, including clinical trials and cost-effectiveness studies, before considering their widespread adoption in primary care. We must also invest in education for physicians, healthcare professionals, and patients, and also advocate for public policies that truly prioritize primary health care. In this process, medical societies can play a key role, providing scientific support and advocating with government authorities. It's also very important to work closely with other countries. We can learn from one another, share experiences, and build regional solutions. Partnerships with global health organizations can further support this effort, by encouraging collaboration and helping to mobilize funding. Lastly, we need national treatment guidelines that reflect our local reality, our local research. This is essential if we want to meet the specific needs of our people. To conclude, I would like to say that challenges in primary care, without a doubt, they are immense. But we must keep moving forward with which is possible, because strengthening primary care is the key to transforming the future of cardiovascular health. So I haven't talked about like new drugs and innovations in drugs, but innovation in attitude in countries that don't have enough resources to manage 200 million people. Thank you very much.
Thank you, Andrea. Compelling arguments. Let's discuss a little bit more about daily pill versus annual pill or semi-annual pill. So let's turn to Dr. Bansilal, a cardiologist whose work on a major polypill study has evolved into commitment to long-term sustainable solutions that promise better adherence. He was part of the SECURE study, which made it to the New England Journal of Medicine, as you remember. Samir, having heard Andrea outline the challenges in the preventive care, how might innovative therapies help transform prevention at the level of primary health care?
Thank you so much, Dr. Nurullah. Really a pleasure to be here. I think when I think about innovation, it really has been a long way when you think about genetic-based therapies, which is really where the focus of this conversation is going. I maybe represent the median age in this room, and I think for us, genetic therapies was a pipe dream. It was something almost felt fictional. Its time was always coming, but never here. And honestly, when you think about it at this point, we're really at a point, inclisiran is a huge example that was talked about earlier, where we have been able to really bring the promise of RNA therapies to the masses. And they really have, with additional studies now, headed towards a primary prevention approach. So I would say that is a prime example of how innovation from a genetic therapy perspective, especially in the field of RNA medicine, I'm sure many of you guys know at this point over the last 6 decades, there have been as many as 6 to 8 Nobel Prizes awarded for RNA-based therapies and the progress in that field. So I would say from that perspective, that is probably the greatest innovation in the space of medical therapy. Its time is really coming now in terms of how it will help beyond the specifics in terms of really elegant precision, in terms of efficacy without any permanent risk if you think about it. But I think more importantly, the aspect related to dosing, convenience, and adherence. We've already seen with inclisiran a 6-monthly dosing. There are others where from a technological perspective, we may even get to an annual dosing platform. So I think from an innovation and adherence perspective for primary care, it really lends itself to a health system approach where you might really be able to get to the masses in a very broad fashion. I think that was mentioned earlier both by Dr. Prabhakar and also Dr. Frieden, is that there is really a lot of work that needs to be done over time from an innovation in policy and health system perspective to incorporate and implement and scale these interventions. But really the promise from a perspective of getting to folks and not turning this disease, which we'd use the words compliance, like it has an element of also something that was said earlier, blame and shame. And I think we really are able to take that and turn that into a technological issue that we're able to work on. I think there are a couple of other related innovations, not in drug therapy per se, but I would say in how we think about diagnosis, risk stratification, and also home-based interventions that will truly lend themselves to a completely reimagined primary care. I'll say to you, maybe 10 years back, you had proposed the Mojis classification, which really lent itself to a very broad thinking in terms of how we think about precision therapy, but also scalable and personalized for patients. In terms of home-based therapies, I think there is a huge wave coming. If you think about how the treatment of glucose monitoring has changed over time, we've gone from something that used to be a painful needle prick to something that is self-monitoring. We're even able to dose people with their insulin on their own. We're able to monitor their trends over time. And I really think primary care from that perspective, putting in certain amount of accountability in the hands of patients themselves, will lend itself to a totally reimagined healthcare system where the health systems, the home-based care, and the innovations in drug delivery will all come together to meaningfully reimagine primary care.
Thank you so much. I think we should go to Tazeen now. You have, I mean, these are both thought-provoking approaches, and I think we should talk to someone who has worked at the grassroots and tried them all. So the familiar single pill model more likely to work in the secondary prevention The other imagines the paradigm of the longer treatment, for example, pairing a lipid-lowering injectable with a flu shot or something like that. So regardless of the path we choose or the combination thereof, reaching communities effectively remains essential. So you have been very successful with the non-physician-led healthcare programs such as COBRA for hypertension. How can such models be adapted to support the rollout of both innovative and traditional treatments with primary care systems around the world, since you have worked in both kinds of settings?
Well, thank you so much, first of all, for having me here, Dr. Nurullah, and it's a great honor. And this is a brilliant discussion, and I think the innovations are very exciting. Regarding your question, like I was previously also alluded to, the question really is how do you get new innovations to the masses and really bring cardiovascular health of the populations, improve cardiovascular health of the populations. And so our experience, and you ask about our experience with the COBRA BPS, the control of blood pressure and risk attenuation study. I'm just going to talk about that study for a couple of minutes. So this was, our motivation for doing the study was really something that we've been talking about, that 1 billion people have uncontrolled hypertension globally. So how can we build a customizable model that is cost-effective, rapidly scalable, sustainable, and acceptable by the people and the communities. So so this was a sort of a non-traditional model of care led by the community health workers in 3 countries, Bangladesh, Pakistan, and Sri Lanka. And we started off with the extensive community engagement, and we trained the community health workers who were already so we built on a model, primary health care, because we wanted to build a model that was, it's very easy to go and say, gee, I'm going to build sort of parallel clinics, hypertension control clinics, and really bring blood pressure control rate down. But that would not be sustainable. And that would neither also be very expensive and would not be scalable. So building on a system that's already there will just bring only the marginal cost. And so that would also be feasible and cost effective. So starting with that was something that so we went and we talked to the stakeholders, the policymakers, the health planners, the communities, and we saw what's there in each of these countries. And in these countries, so not bringing our specialist physician, but working with the community physicians who are already practicing in the communities, and each one of these countries, as I mentioned, has an extensive community health worker program, trusted people who go in the communities and provide maternal and child care. And we said, well, these people are already providing maternal and child care, why can they not provide hypertension care also, right? And so we trained them, we gave them Omron, and we had to have very standardized reading of blood pressure, because we don't want to over-treat people either. And we want to give, so we trained them, and very good training is important. Competency assessments are important, so it needed some work. So we trained them, we gave them the Omron, we trained them very well in the referral and all the hypertension training, trained them in the DASH diet because that was evidence-based, and we changed the DASH diet recipes that was applicable to each of the 3 countries. So that was involved the nutritionists, the dietitians, so local diets, the South Asian diets in Pakistan, in Bangladesh, and in Sri Lanka. So we developed those dietary guidelines and compliance adherence training about, and so when they hear this from people who are in their communities, the community health workers, this is what you have to do. So the community health worker would go to their home, sit down, and when she sat and we chatted with the lady of the house, the entire household gathered around her. Now think about the impact that will have also on the children who would be listening to that conversation. So that's what the impact, and I'll talk about the results in a second. So she would go home, she would check the blood pressure, and you know, if they're elevated, she would refer. Now we trained the community GPs in the updated guidelines and ensured that they were prescribing low-cost, generic, high-quality medications. Again, in each of the 3 countries, and they are free in Sri Lanka, not necessarily free in Pakistan and Bangladesh, so patients still had to pay for them. We didn't wait for arguing it's brilliant if the medications are free in all of the countries, but that would take a very long time to convince the policymakers to provide them free. We wanted something that was practical and something that we could do. So that was our model and a referral loop. So and the community health worker would do a lot of counseling, coping strategies, stress management. And so we followed the patients for 2 years. This was a cluster randomized trial. At the end of 2 years, blood pressure came very nicely down in the intervention arms compared to the control arm, 5 millimeter mercury difference across the 3 countries and in each of the 3 countries, which translates to about 20% reduction in cardiovascular morbidity and mortality at a population level. It was very cost effective as well. We also, in a proof of concept study, we did assess the blood pressure level of the children who were in the same household, and those age-related rise in blood pressures also declined. So there's a spillover effect on the entire community of this approach also, which is, so I would want to mention that. And another very positive thing was the trust that we had built, the acceptability these are women in very conservative societies of Pakistan and Bangladesh, for example, also in Sri Lanka. These are South Asian women, young women who are going to the homes and measuring blood pressure of men, and men are listening to them. So their social status was elevated. They felt rewarded. They're like, oh, we really like, because we didn't have that status in the community, and now their status was elevated. So that was very rewarding for them. And because before we started this project, we got a pushback saying this is probably not going to work, they're not going to get paid, there's going to be resistance. So I think all those biases need to just go out of the window, and we need to go and see how. So this was and even the community health workers who are not in the program were coming and say, you need to recruit us, we want to be part of this program as well. So it was valued by the providers, because the patients started, providers do not have the time. As much as we would love to sit and talk to the patients for a very long time, the reality of the situation is all across the world, it's underfunded, primary care is underfunded. It's as much as we do, they need to say a little bit, but unfortunately, the reality is just not, we don't have the time to sit and chat with our patients for half an hour. It's just not going to happen. So they need to reinforce, but there needs to be the task-shifted model, the team-based approach. It needs to be a non-physician healthcare worker. They work with you, and that team-based care model needs to happen.
So thank you, and I'm sorry that I had to.
No, that's okay. I've been.
And because I had to follow the. The last question to Dr. Hegman before I ask for one single liner from everyone. If we are going to really reimagine the healthcare here, as Dr. Bansilal just advocated, and if we agree to engage the community into believing the reimagined healthcare, how we would ensure that these advanced technologies are financially accessible? We know such approach is possible, but is it truly sustainable? And so you have carried major advances to the bottom billion time and again. Could you share some of the examples, although you did talk about it during your pace setter lecture, but what would be the insights that you would give us so that one could, when one looks at the program development or policy development, one can incorporate them into the public health strategies?
Yeah, a couple of thoughts. I think, first of all, we need to ask ourselves, what is the cost of inaction? And we know that the current systems don't deliver, and I believe it is a calculation by the World Heart Federation that cardiovascular disease is going to amount to a triggering $1 trillion by 2030. So that gives us a lot of room to invest. And I would also like to make sure that we understand healthcare not as an expense item, but as an investment in future prosperity. And it's been shown over and over again that $1 invested in healthcare yields returns that you would never get anywhere else. It's about a factor of 15. So I think the financial question to me almost becomes one that has been answered over and over again in a positive way. So how do we make this work short term? And let me reflect on my time when I was still a treating physician. HIV/AIDS didn't even have a terminology back then, let alone antiretroviral therapy didn't even exist. And it was totally unperceivable that antiretroviral therapy would be available essentially now to every patient on this planet who needs it. So I think also those previous approaches show that if we put our minds to it, our creativity, and if we work together, then a lot can happen that currently in our maybe constrained mindset and setting we can't even imagine. Another example, for instance, cardiovascular, chronic heart failure, the combination therapy of valsartan and sacubitril. We have now more patients in low and middle income countries on treatment than we have in high income countries. And again, it requires creativity from all parts, but certainly from our perspective, there is a lot that can be done. We need to commit to making innovation accessible as broadly as possible, and we need to be as creative in finding those models as we are creative in developing our new medicines and treatment algorithms.
Thank you. And if we could go one by one, starting from Dr. Bansilal.
Yeah, I'll just say that I think we really need to embrace innovation, but then execute the basics with discipline. Thank you.
Tazeen.
Scale up the evidence-based strategies that we already know they've been shown to be successful in many countries. We need to scale them up.
Andrea.
I think I would say that primary prevention needs more funding, and we need to adapt our decisions to each country, to each place, and to each population.
So the focus needs to change. And Dr. Higman.
Yeah, it seems to be impossible until it's been accomplished. I think that was Nelson Mandela.
I think we can stop here. It's showing me exactly 000 here. Thank you very much. And